The topic of the lecture was chronic lymphocytic leukemia, transition to a new era, and that's really reflecting the tremendous amount of change that's occurred in CLL over the last 15 years with the introduction of the fludarabine, cyclophosphamide and rituximab combination, and also the tremendous amount of excitement and novel developments that have occurred in the last 4 or 5 years in particular. So there's been two key elements to that. One is novel biological and genetic findings that have kind of given us a lot of information about why the disease progresses in some and not in others. And then on the other hand, there's a lot of novel therapies that are making a huge difference to patients. I like to refer to this as what I call the triple revolution in chronic lymphocytic leukemia. The first part of that is the immunochemotherapy revolution, and that's really the introduction of this fludarabine, cyclophosphamide, rituximab combination, or FCR for short. So that's taken patients from having a median progression-free survival of about 18 months, 20 months or thereabouts to 57 months with the FCR combination. One of the things that we've done in our institution is, and in our group, the Australian Leukaemia and Lymphoma Group, the early studies in this setting focused on a younger cohort of patients with CLL, typically around the age of 60. But the typical age of patients with CLL is in fact into their 70s. And so we ran a dose reduction study looking at 3 dose de-escalation steps of FCR, and showed that FCR really could be administered safely, either at a reduced dose to begin with, or using a early stopping rule in the event of toxicity. And that's really achieved very good outcomes in that setting. Now, on another footing, one of the major studies that has been run, the German CLL-8 study, and also Professor Michael Keating's group at MD Anderson, both of those have now got long-term follow-up of patients treated with FCR. And if you're in this group with favourable genetics, so-called mutated group, and also achieve a molecular MRD negativity or no detectable disease, then those patients have got disease, no evidence of disease, some 12 years out from treatment. So FCR really ought to remain the cornerstone of our treatment for the present time. That's the kind of second component, is the molecular revolution. And while I'm not an expert in that area, there's been a huge amount of data emerging on the major genetic abnormalities that are present in chronic lymphocytic leukemia. So they include 17p deletion, or the TP53 locus, 11q or the ATM locus, and other abnormalities called Notch1, SF3B1, BRIC3, and others. And what they're doing is advising us about who's more likely to progress and who's more likely to have disease evolution into a high-grade lymphoma called Richter's transformation. The third element, arguably the most exciting when you look at it overall, is the advent of novel therapies. Now, there's 2 broad classes of these novel therapies. The first group are ones that block molecules within the B-cell receptor pathway in the CLL cell itself. And the 2 key drugs that have been examined in that are ibrutinib. It's taken orally. It blocks a protein called Bruton's tyrosine kinase, and it's remarkably effective in patients that have got relapsed and refractory disease across what we considered to be all of the adverse risk factors that were present in the disease. So that's been tremendously exciting. There's a huge amount of work that's been taken place with 3 very large trials, one in the relapsed and refractory setting, one in the very high-risk 17p deleted group, and just very recently at the American Society of Haematology last year, and then published in the New England Journal also in December last year, using this drug in frontline therapy, the so-called RESONATE studies. With regard to the biology of CLL, Basically, the primary step is really firstly the development of a CLL clone. And then secondarily, it's whether or not that progresses or whether it doesn't. And a lot of that is influenced by the microenvironment. Now, in reality, a lot of these new drugs, ibrutinib, idelalisib, both work by blocking the survival and proliferation signals that the CLL cells are receiving in the microenvironment. So the microenvironment is very important for the survival and proliferation of CLL cells and for the maintenance of the disease. And really, many of these new drugs are working in that environment by blocking the survival and proliferation signal. As these trials with ibrutinib, with idelalisib, and then with venetoclax, which has just very recently been approved in the US, each of these drugs we're starting to see emergent toxicities. Now, ibrutinib is a very well tolerated drug, but there are emergent toxicities. Firstly, low blood counts, particularly neutropenia. Bleeding and bruising is very, very common with this agent. It's due to inhibition of platelet function. But we've also seen a signal coming through of atrial fibrillation in about 7% of patients in all of the larger trials. And as a result of the atrial fibrillation, it's got problems of its own that need to be dealt with, but also a significant proportion of people drop off the utilisation and need to discontinue the drug. With regard to idelalisib, that blocks the PI3 kinase molecule, also in the B-cell receptor pathway, there's a number of toxicities that have actually required new warnings for utilisation of that drug. Firstly, emerging infections at a higher rate. Secondly, low blood counts, and so there's a number of prophylaxis measures that have been recommended. And then finally, the drug venetoclax, which works in a slightly different way. It blocks BCL2, and therefore the cells undergo apoptosis. Now, the recent study that's been published in the very, very high risk 17p deleted relapsed and refractory patients has had very favourable responses, but this drug is also associated with neutropenia. When it goes into widespread practice, it will be very, very important to follow the tumour lysis syndrome prophylaxis. And there's also a number of patients with this high-risk disease that are coming off the drug because of progressive disease. So while they're tremendous advances, we also need to be cognizant of the risks and potential problems associated with their use. These new agents are incredibly exciting because they're really extremely useful drugs in the patient with relapsed and refractory disease, but we do need to be cautious and cognizant of the potential side effects and adverse events as we move forward with these agents.